Thank you so much, Maureen, for that amazing summary of your book. So the first question I have, it says, your book is different from Gary Getty's Medicine Unbundled in that your research involved access to government documentation. Have you been approached by those who are contemplating suing for treatment in the Indian hospitals?
That's right. My book is different than Getty's. It's important to lay down the structure or try to understand the larger context of Indian hospitals before you can begin to understand why they existed or why the treatment in them was so different from the treatment that non-Indigenous people might receive in Canada. To put into context people's lived experience of the hospitals and some of the very scarring experiences that they had and that Gary Getty reproduces in his book.
Thanks, Maureen. It's Margaret. There's another point that was raised earlier by one of our participants, which is, can you comment at all on the kind of health care and service that communities received where there were not Indian hospitals? Did your research look into that?
Very often people were moved. The Inuit, for instance, they're the most obvious example. But folks were moved to the Charles Council Indian Hospital in Edmonton from the north. So it was deemed easier, less expensive, more convenient to move patients rather than establish healthcare facilities in the north. The images I showed you of the Charles Council Hospital, that's the old hospital. In 1967, it was replaced with a new hospital. And if anybody knows Edmonton at all, that building, that 1967 building still stands. It was eventually taken over by the province and then completely abandoned because it was full of asbestos. And it was left as an eyesore in that neighborhood. I think there's plans now to develop it into condos, if you can imagine. But in 1967, when the federal government rebuilt that hospital, while, of course, it was shutting down all other Indian hospitals, it called the Charles Council Hospital, and they dropped the name Indian, so they called it the Charles Council Hospital as a gift, centennial gift from Canada to the north. Of course, people in the north might have wondered why it wasn't actually in the north, but the point was that it would be a resource for the north and that Indigenous people would continue to be moved to care rather than have hospital care closer to them.
Thanks, Maureen. Why do you think there was a different approach in Alaska in the planning against TB compared to Canada's approach?
I'm not exactly an expert on the Alaskan system. I think that some historians have compared the care in Alaska to the Canadian system, and I would suggest that part of it is situated in the different political climates, political systems between Canada and the United States. I think the Alaska example focused on some community training so Indigenous people could run their own hospitals. And it is surprising and kind of shocking that Canada did not undertake any training. And I think it speaks to the overwhelming paternalism of the Canadian bureaucracy that was Percy Moore and a surprisingly small number of white men who ran that bureaucracy and saw Indigenous people as patients or ex-patients. And that's all. Couldn't imagine Indigenous people being trained in the healthcare professions or paraprofessions.
So could you comment on the involuntary sterilization of Indigenous women in Canadian hospitals today? I know that's outside your scope, but maybe it ties into the whole idea of patient consent that we see running throughout the book and or the lack of patient consent.
Yeah, not for this book, but my subsequent research in reproductive politics in Canada in the 1970s. There is unfortunately a history of involuntary sterilization of women, principally in Indian hospitals. And again, it goes back to this mothering paternalism where healthcare professionals deemed it up to them to decide when women had had enough children. The policy for a very long time was that women in the north would be evacuated to the south for their first and fifth pregnancies. the rationale was, the first might be, complicated, and the fifth, then she could, of course, be sterilized. And, of course, this happened very often without the patient's knowledge or consent. And even where there were consent forms, and there was quite a scandal in 1973 about this very issue, that a woman was sterilized against her will without her knowledge at the Charles Camsell Hospital, and it made, the national press, CBC TV. And the government claimed that this couldn't have happened and that they had consent forms. But the consent forms, when you look at them, were in fact documents that absolved the physicians of any legal liability. They might use the word sterile or something to that effect. The rest of it was legalese that very often, or that never actually described what would be happening, that it would actually be an operation, and that they were often competent interpreters in the hospitals to explain to women in their own language what exactly they were being assigned.
Thanks, Maureen. One of our participants has asked, did your research uncover ways that people with mental health difficulties were quote-unquote treated or managed? Is it true that Indigenous people at residential schools who were not compliant with the regime there were transferred to the Indian hospitals?
Certainly, patients were transferred from residential schools to hospitals and back again. I'm not, always clear on the medical reasons, whether it was illness or, as you say, mental illness, but there was a constant back and forth. And kind of imagine one of the rationales for the Indian hospitals was to treat those kids who were made ill in residential schools. The other option would be to send them home, and the point of the residential schools was to remove children, from their parents, from their homes, from their communities. And so the Indian hospitals work in tandem with residential schools to that end.
Thanks, Maureen. I have another question coming in from someone wondering if there's any estimation of the number of children who suffered abuse at Indian hospitals, whether it be physical or sexual abuse. Maybe you could also just give us an estimation of how many people went through these hospitals, maybe, as well.
Yeah, the questions of abuse in the hospitals, these are not things that typically get documented, in the archival record. I didn't ever see any patient records. It doesn't mean that they don't exist, but unless National Health and Welfare transferred those records to the National Archives, researchers wouldn't have access to them. If we recall how the residential school system, the most horrendous abuses that we know about from that come from survivors' stories. This is what happened to me. Even in the residential school system, that those awful forms of abuse, they don't tend to get documented. So it is when survivors are allowed to tell their stories and Canadians are ready to listen to those stories that we will know more about what happened in Indian hospitals. My book is really just, a preliminary study to try to understand how they came to be and why they came to be.
Thanks, Maureen. Another question regarding British Columbia, which does not have numbered treaties, although there are some Douglas treaties on Vancouver Island. Were there more Indian hospitals in the province than the one in Nanaimo?
Yeah, there's the one in Nanaimo, and they also had one at Miller Bay at Prince Rupert. Both of those, of course, were redundant military facilities. And there was also Kokolitsa at Chilliwack. So there were at least 3 in BC.
Thanks. I have a question here. Someone is wanting to ask you briefly, what led you to study this topic?
Well, my first book, Medicine That Walks, it was an examination of the impact of colonialism on the health of Indigenous people on the prairies from about the 1880s to the 1940s or so, the treaty period and beyond. I mean, that was a study of economizing, parsimony, neglect, trying to contain Indigenous people and their illnesses to reserves. And at the end of that study, in the records, I started to see things about these Indian hospitals. And it allowed me to finish that book on a mild note of optimism that, finally the state was directing some funds to the medical treatment of Indigenous people. And so I was interested in those hospitals. And of course, my optimism faded quickly once I started to understand that the hospitals were, as I said earlier, not an attempt to isolate less, but an attempt to isolate better in an age where the discourse had changed from, the impact of disease on Indigenous people to the threat that Indigenous people pose to the national health.
I think that leads nicely into the next question, Maureen, which was, when the apprehension order was introduced, was it limited to infectious diseases such as tuberculosis, or was there more broad concern about separating people who were going sent to Indian hospitals?
Yeah, so that slide I showed of Form 7018C apprehension order was for anyone who left hospital against medical advice. They called it running away, and they would send the RCMP after them. And it wasn't tied to infectious disease necessarily. I mean, every province or community had its own public health act. People can't just, wander around with infectious disease. But the point of the Indian health regulations and the point of it being part of the Indian Act was because those public health regulations were not deemed as strong enough for Indian health services purposes. Because, you can send somebody to hospital, but if they leave against medical advice, for the most part, people's freedom of movement is not interfered with. But Indigenous patients, there were lots of examples in the records of patients being returned to hospital in chains.
Okay, great. Thanks, Maureen. I have another question here that the attendee says, as an Indigenous person, they would like to say that Indigenous people are still being treated differently within healthcare system, even without Indian hospitals. So how do you think this history can be used to invoke change at all healthcare levels? Is it through policies or is it through education?
I had those answers, but I would suggest both. It's important that Canadians begin to learn their own history. Canadians have only just recently begun any kind of serious dialogue about residential schools. And the Indian hospitals, like the residential schools, they're these kind of nodes in a larger net or web of policies that were intended to, restrict, repress, and remake Indigenous people. And until Canadians begin to know their own history, it's difficult to make changes. I brought to all the new book just published by Mary Jane McCallum and Adele Perry called Structures of Indifference, about the death of Brian Sinclair in the Winnipeg emergency room. And in September 2008, after sitting in the emergency room for 34 hours, that's still happening. The inquiry into that didn't ever examine notions of racism as a factor in what happened.
Thanks, Maureen. Did you find any evidence of early drug testing within Indian health services, maybe the tuberculosis vaccination or early antibiotic testing?
There was certainly the BCG vaccine, the tuberculosis vaccine, was first tested on Indigenous infants in southern Saskatchewan in the 1930s. Indeed, the Fort Qu'Appelle Indian Hospital, I showed you a slide of that, built in 1936, was actually built to accommodate that vaccine trial. It was seen as necessary for the BCG vaccine to only vaccinate those who had never been exposed to tuberculosis. And they wanted to vaccinate newborns, but they wanted to vaccinate newborns born in hospital. And at the time, most Indigenous women in southern Saskatchewan would not have chosen or did not have access to hospital birth. So the Fort Qu'Appelle Indian Hospital was built in order to provide hospital births, but in significant ways in order to further the BCG vaccine trial. which interestingly, that trial ended in 1945, so it ran for 20 years or so. And the important results were that certainly the vaccinated groups were protected to some extent from tuberculosis over control groups these are the infants born at home. But a good 20% of all of the infants in the trial were dead by the 5th birthday, and not because of tuberculosis, but because of gastroenteritis, pneumonia, classic diseases of poverty. So when you look at the vaccine trial records, it does show BCG vaccine as beneficial, but the larger question or the larger result was all of these children died before their 5th birthday, and tuberculosis wasn't the biggest threat to these children. But of course, tuberculosis, unlike poverty, can spread to non-Indigenous communities. And so it was significant to have a BCG vaccine for Indigenous communities, which is still offered in many jurisdictions.
Okay, thanks, Maureen. I have a question here from someone asking if in your research you came across any traditional ways of knowing or approaches used by Indigenous people for TB treatment.
My research tended to be in the archival record. I know that the research for my first book, was looking at an earlier period, 1880s to 1940s. There were efforts codified in the Indian Act to try to repress the work of Indigenous healers because they were seen as a very real competition to Western medicine, and in particular to missionaries and their brand of medicine. So I was able to talk to people who understood the healing value of the plants and other resources of an earlier time. So there were treatments for malaise, fever, coughing, some of the symptoms for tuberculosis. One of the most ingenious is in the sweat lodge itself, where oftentimes is built of bent willow branches into a dome and then covered with furs or, other evergreen fronds, that kind of thing. And then inside, rocks are heated and steam is created. It's a physical plus spiritual cleansing. But under heat, of course, the willow branches give off certain steam themselves. This is where the active ingredient in aspirin comes from. It comes from willow branches. So the sweat lodge itself would act as a soothing physical treatment as well as spiritual for anybody that had cough or aches or pain. So that kind of understanding of how the people, given access to their own resources and environment and not forced to remain on reserve or be restricted from traveling. And also before a time when much of the prairie, for instance, before it was all under cultivation, people did have access to the resources for good health.
Thanks, Maureen. I think the next question is a little bit related. Somebody is asking, what was the care like for Indigenous peoples outside of the hospitals for primary care? Were there any structures in place for that or public health outside of these hospitals?
Right. Indian Health Service, besides the Indian hospitals, they also established what they called nursing stations in communities. And these fairly small, one, maybe two nurses in a building with one, maybe, or two beds to treat folks from the community or to act as a link to the Indian hospitals themselves. Westernized medicine was in communities, and that's how the people who were ill in communities would come to the notice of Indian Health Service, and they were very ill to be evacuated out of their communities and to Indian hospitals. There was, a presence in communities of Indian Health Services.
Thanks, Maureen. I just have a question myself. I'm wondering if you can elaborate a bit on the role of Aboriginal employees in terms of being patient liaisons, particularly for paid translators and being cultural brokers and support for patients.
That was, a fascinating part of the research to realize how many Indigenous people actually worked in these hospitals, because they don't tend to intrude on the record at all, because it's all about the nurses, the doctors, and they're the ones creating the records for the most part. But Indigenous workers were the ward aides or the domestic help, the janitors, the drivers. They were doing the work that was first paid and the least trained. But their presence in hospital created the conditions whereby they could act as you say, cultural brokers and translators for vulnerable patients, whether it's infants and children or their own elders. And it was a valuable source of wage labor in many communities. And over time, then, these Indian hospitals very much become community institutions. The communities start talking about them as our hospital. This is our hospital. And that's why in the 1960s, when the Indian Health Service wanted to get out of the hospital business, as they put it, and start closing down these hospitals, they met considerable resistance from communities who had come to understand that not only were the hospitals an acknowledgement of the treaty right to healthcare, but they were also important community institutions. And the notion that the government would simply shut them and take money that was earmarked for healthcare for Indigenous people and take that money and invest it in non-Indigenous community hospitals was hard for many communities to accept.
Thanks, Maureen. I see there's questions and comments regarding the complexities of how healthcare currently is delivered to First Nations and other Indigenous peoples, and that's probably beyond the scope of today's webinar. But in the interim, I just wanted to ask you myself, in writing the book, have you had a chance to work with local systems or local peoples regarding how they can use your history to inform their hopefully better practice in TB management and care?
You know, I don't presume to influence how people are cared for, but I know that in giving talks to the Webinaire Center, for instance, in Ottawa, an Indigenous healthcare center, comment from the staff was, we're often faced with patients who wait too long to come for healthcare or are so reluctant to access Western medicine. And knowing the history sometimes helps for the healthcare providers to understand why there is this legacy of mistrust between communities and healthcare providers.
Thanks, Maureen. We're just wondering if you have any thoughts or information about the difference in services that are covered by provincial health plans versus Indian health.
As you know, I'm a historian, so I'm certainly not an expert on current issues at all. But I know that the non-insured health benefits plan is a source of constant frustration. The government, rather than honoring its commitment to healthcare for Indigenous people, acts as just the payer of last resort, the insurer of last resort. And it creates problems for people's health, their access to care that is unnecessary. But that's just, my uninformed view of the current situation. But I do know that the non-insured health benefits program is like the other healthcare programs in the past of the federal government, it's always kind of grudgingly extended to people that need care.
Well, thank you very much, Maureen, and thank you to so many people who attended this webinar. I think the information that you shared was very important, and that the discussion that we've had after your presentation has been very valuable. There will be other information available about this webinar series from the National Collaborating Centers for Public Health at nccph.ca. And as well, you may find additional information about tuberculosis and the work that the NCCs are doing in this area at the National Collaborating Center for Aboriginal Health and the National Collaborating Center for Infectious Diseases. Thank you all so much, and thank you again to our guest, Dr. Maureen Lux.
Thank you for having me.